Kritika. Dr. Kirtika, can
You can
share your slide? 1 minute, sir. 1 minute.
Yeah.
Dr. Kirtika, can you share your presentation?
Yeah, you can start.
Yeah, Dr. Ramkrishna, can you start recording?
Yeah, I can hear you, you people, and Dr.
Yeah, I welcome Dr. Krishnan and Dr. Suryan. They are today's moderator, and Dr. Kirtika is presenting the case. So, Dr. Suryan and Krishnan, over to you, followed by Dr. Kirtika. You can start. Yeah, Suryan sir, you can start model.
Good evening, Dr. Shailesh. I think we can start the session. So,
Yeah, Dr. Kirtika, you can start presenting.
Dr. Krishnan is here, sir?
Yeah, I can hear Dr. Kurian. Yeah.
Yes, sir. Okay, sir.
Yeah, Dr. Kirtika, can you start? Mm, yeah.
Dr. Kritika can start. You can hear?
Uh, Dr. Kirtika, you can unmute yourself, then you can start.
So you're hearing me, sir?
Yeah, you can start. Go to the first slide.
Okay, sir.
Yeah, start slideshow. Okay, start.
Seeing my slides, sir?
Yes, go ahead.
Okay, sir.
Yeah, we can see. Start.
So 1 minute, sir. I'm not hearing you, sir. 1 minute, sir.
You can hear now?
Sir, the audio is not here.
You have to use only one device, otherwise echo will be there. You can log out from the other device.
Start, doctor. Doctor, we can see your slides. You start presenting. You can hear?
Yes, sir. Yes, ma'am. I can hear, ma'am.
Start.
Good evening, ma'am.
Krishnan sir, yes,
Start. Yeah.
The patient is a 65-year-old right-handed maid, farmer by occupation, presented with chief complaints of difficulty in getting up from squatting position, for 25 days, difficulty in raising arm above shoulder for 20 days, difficulty in swallowing for the past 5 days. The patient was apparently normal until 25 days back when he noticed difficulty in getting up from the squatting position climbing staircase, where he noted history of buckling of knees, more predominantly when climbing downstairs, history of plainness of both lower limbs present, noticed by him while grazing cows in the field, and also had difficulty in carrying out his day-to-day activities. All these symptoms are acute in onset and progressive for the past 25 days. 5 days into the illness, he developed difficulty in lifting arm above the shoulder, combing hair, taking foot to mouth. Patient also noticed thinning of both arms without twitching. No history of difficulty in buttoning or unbuttoning shirts and mixing foods. No history of difficulty in rolling over bed. History of difficulty in lifting head off the pillow, but there was no history of cramps or muscle pain, fatigability, or diurnal variability of these weakness. No history of exercise intolerance present. No history of high colored urine. He was able to perceive all sensation, both pain, temperature. No history of cortical sensation of both feet. No history of electric shock-like sensation radiating upwards or downwards or to arms while flexing or extending in the neck. No history of back pain, neck pain, or radiating pain. 20 days after the onset of illness, he developed difficulty in opening the mouth fully, but he was able to chew the food, clench the jaw. No history of dropping of jaw present, not associated with pain over the temporomandibular joint. History of nasal regurgitation for solids and liquids present. History of slurring of speech present with nasal intonation of voice. History of difficulty in protruding the tongue and rolling the tongue from side to side and manipulating the food. There was no associated pseudobulbar effect. He was able to perceive other cranial nerves, other cranial nerve history include smell, color. Uh, he was able to move eyeballs in all directions. No history of drooping of eyelids or double vision. Able to appreciate the sensation of a face, wrinkle the forehead. No history of deviation of angle of mouth or drooling of saliva. No history of hard of hearing, tinnitus or oral fullness. No history of difficulty in turning head from side to side. No history of bladder bowel disturbance.
Hello.
No history of yes, ma'am. Hello. Yes, ma'am.
Hello. Proceed.
Ma'am. Ma'am, can I present, ma'am?
Okay. Dr. Kritika, can you hear? You continue to present.
Okay,
Yeah.
sir. No history of slowness of activities, no history of involuntary movements, no history of incoordination of limbs, no history of tremulousness of hands, no history of seizures, no history of loss of consciousness or memory disturbances, no history of autonomic disturbances in the form of dryness of skin, loss of sweating, postural giddiness, or palpitation. No history of fever, rash, headache, vomiting, abdominal pain, diarrhea preceding this illness, no history of jaundice, no history of cough with expectoration, no history of breathlessness. No history of loss of weight or loss of appetite, but during the hospital stay, he had significant loss of weight, sir. Past history, not
You
known
can
to
analyze the history and then we will take it forward.
yes, sir. Starting from the present complaint, sir.
Yes.
The initial complaint started with difficulty in getting the squatting position, sir.
So what does
And
that indicate?
that indicates that the patient might have a uh, proximal muscle weakness or
Yeah, just tell me the neurological causes for difficulty in getting up from from squatting position.
Yes, ma'am. For getting up from squatting position, the patient might uh, from starting from element axis. I would like to place, ma'am. Starting from muscle, NMJ, and the proximal radicals might be involved, sir. Involved, ma'am. So predominantly a proximal muscle weakness or a proximal or a radiculopathy or a neuromuscular junction problem have might present as a difficulty in getting up from squatting position. Hello, sir. Hello, sir.
Hello. Voice is not clear.
This is not clear, sir.
Continue.
Yes, sir. There was also buckling of knees and the flailness of both lower limbs present.
What do you mean by flailness of both lower limb?
That was hypotonicity, sir. Flabby feeling of the lower
See,
limbs.
that is not indicated by flailness. Flailness is when there is no power and there is free movement around a particular joint in all possible directions. Like in if elbow joint, it moves in flexion and extension. So if you are looking at an ankle joint, if the patient does not have any power and the joint is able to freely move in all directions, that is when you label it as a flail foot. Okay, so flailness of limb to indicate a hypotonicity is not a correct usage.
But he told that there was a flabbiness. That is, he was not feeling the firmness of the muscle.
That you can say the way the patient feels. See, the flailness is a scientific term, is what I meant. You can say that the patient felt that his limbs were, these muscles were not stiff. Patients with hypotonia of muscles often lose the muscle contour. So the flabby feel. So when you are examining tone, that is something that you have to touch the muscle and feel whether the tone is present. The muscle contours might be lost. So that the patient might tell you. So you have to say that the patient feels that the muscles have become loose, or the patient, so patient is not going to tell flail, right? History is something that has to be given in the patient's own terms. Flail foot is a scientific term. It indicates that at a particular joint all the muscles are weak and there is free movement with the a extreme range of motion. The patient's joint is able to move around because of the complete weakness of muscles in and around that joint. That you cannot use in history. If you are using that, then I will think that this patient has 0/5 power around that joint, which is not true in your case.
Yes. Okay, sir. Yes, sir. I will modify the history, sir.
So in
He,
your patient, you said the different differentials for difficulty in getting a sitting position. I know. So in this particular case, what do you think the cause is?
had associated buckling of knees and the loss
Buckling of
of
knees is due to which muscle involvement?
quadriceps, sir. Quadriceps.
Okay, and you told more difficulty in climbing downstairs, right?
Yes, sir. Yes, sir.
Okay, for climbing downstairs, which muscle is important?
Knee extensor, sir. Quadriceps, sir.
For climbing upstairs, which muscle is important?
Hip flexion, sir.
Which muscle is important for climbing upstairs?
Hip flexion,
Muscle.
knee flexion. Sir, iliopsoas, sir.
Which muscle is important for climbing upstairs?
Iliopsoas.
Iliopsoas.
Yes, sir.
It's more
Hamstring, sir.
gluteus.
Hamstring.
Hamstrings.
There should also be knee flexion to climb upstairs, sir.
Okay. Go ahead.
Iliopsoas, hamstrings.
One important muscle you have missed, doctor. What is the muscle which is involved in unlocking the knee joint for flexion?
Unlocking the knee.
Am I audible?
Yeah, sir. Yeah, sir.
So see, hip flexion is important. All of these are and the knee has to flex. So hamstrings are important. But see, which muscle is involved in locking the knee joint?
The knee joint is quadriceps, sir.
Yeah, that is why when the patient is climbing down, when you are not able to lock the knee, there is a difficulty in climbing downstairs. And also when walking, the center of gravity of the patient's upper body comes forward, there is a chance of the patient to buckle. But if a patient has to climb, the first thing that has to happen is that the knee joint has to be unlocked. And the unlocking is done by? popliteus. Okay.
Okay, sir.
So popliteus is the muscle which unlocks the knee joint and facilitates climbing. It is a very important muscle there. No, and in addition to that, you need hip flexion, knee flexion also. What is back kneeling?
Back kneeling, sir.
Yeah. What is back kneeling?
We don't know.
That is otherwise called genu recurvatum. What is that? Where do you
So
see
there
that?
will be anterior curvature of the uh,
Anterior curvature. It's a concavity anteriorly, so the knees tend to go backward. When patients who have got quadriceps weakness, they have a hyperextended knee. That is called a genu recurvatum, otherwise called a back kneeling. Okay.
Yes, sir.
Doctor, are you able to hear me?
Yes, sir. I'm able to hear, sir. Yes, sir. I understand.
Yeah, so you are in this particular patient, you have weakness of the gluteal muscles, and according to your history, there is a buckling of knee, there is involvement of
Quadriceps.
quadriceps muscles. Continue. Which other muscles?
Since the difficulty is squatting, getting up from squatting position alone, sir, there is no distal weakness. That is, he is able to catch hold of the slippers. Ankle dorsiflexors are not involved, sir. And spine extensors should also be involved in this patient. Can be involved in this patient.
Upper
Why
limbs
are you
also you
bringing
tell
in
doctor, upper limb,
upper limb also?
upper
You
limbs.
say. Move to the next slide.
Yes, sir. Yes, sir. He after 5 days into the illness, he developed both upper limb weakness, proximal more than distal, sir.
So what are his day-to-day activities which he is not able to do with his upper limbs?
Usually he goes to grazes the cattle, sir. He
Okay.
takes water and pours it in the big pot for the cow to have the water. He was able to catch hold of the pot, but he was not able to lift it and pour it, sir.
Okay. So what
And
does it
he
mean?
used to lift the fodder for the cattle. He was
Okay.
able to catch hold of the fodder. He was not able to keep it in the head, sir. And he was not able to, after mixing the feed for the cattle, he was not able to get up independently, sir. He used to catch hold of the nearby vessel and then only get up, sir.
And he can able to get up from sitting in a chair or a cot, he can get up?
Initially, he was able to get up from the chair, sir, chair and bed. But during the course of hospital stay, he also had difficulty in getting up from the bed also, sir.
Okay. Continue,
So both,
continue.
sir,
Continue, doctor.
yes, sir. There was history of difficulty in lifting head off the pillow, sir. Indicates
So,
a neck
ah,
flexor weakness.
okay. So which muscle is important for neck flexors?
Long is capitis, bilateral sternocleidomastoid, sir.
Okay.
Tendinous anterior, tendinous medius.
Continue, continue.
Longissimus coli also. There was no history of myalgia or muscle pain, no history of diurnal variability or exercise intolerance. And there was no sensory symptoms.
Okay.
20 days into the illness, he also had difficulty in opening the mouth fully, but he was able to chew the food and clench the teeth, sir. There was no history of jaw dropping, sir. There was also no associated pain over the TMJ joint. This indicates that the patient might have a local pathology which restricts his jaw closing, sir. Sorry, jaw opening, sir.
So difficulty in opening mouth, you feel it is not due to a weakness of the muscle, but you feel it is due to a local cause.
Yes, sir.
What long you have probably said that there is no TMJ tenderness there, into this spectrum of a patient having muscle weakness. Why do you want to bring in a local cause? What is the did the patient have any pain? No, why do you, what kind of a local cause are you considering?
Because he had, there was no jaw drops, but there is a muscle weakness, there will be a jaw drop. They usually use the hand to close the jaw, sir. But this is not the case in this patient, sir.
What happens if the patient has got a bifacial weakness?
Then he is not able to purse the lips, sir. There will be drooling of saliva from angle of the mouth bilaterally.
Doctor, you mean to say this patient has jaw weakness, right?
Yes, sir.
You mean to say this patient has jaw weakness, and you also told there is no TM joint tenderness. So you want to localize to the neuroaxis or musculoskeletal? That's what Dr. Kurian is asking you.
I think localize it to the musculoskeletal, sir.
What
Because
musculoskeletal pathology you tell me in this patient?
there may be contractions involving the lateral pterygoid muscle, which restricts the full opening of the jaw.
Okay, what is the reason for the contractures?
The systemic process itself might cause contractions. Sir.
What can cause?
So if the patient has a inflammatory etiology of the muscle of the proximal weakness, then we can explain it due to the contractions involving the
So that
lateral pterygoid muscle.
inflammation of the muscle is a part of neuroaxis only, no? If at all you want to tell that as the cause, inflammation of the muscle is again a part of this neuroaxis only, no?
Yes, sir. Yes, sir.
Then why you want to tell it as a different pathology?
Oh,
It's a part of the same illness only, no?
yes, sir. Yes, sir. Yes,
So whenever you try to explain a particular symptomatology, you have to put all your things in a single basket. If you try to explain with two different etiologies, you will be trapped. Okay.
Okay, sir.
Okay. Continue. So you mean to say cranial nerve is involved, right?
Yes, sir.
So with this history, what are the cranial nerves involved in this patient?
Doctor, another thing. What do you mean by contracture?
The shortening of muscle is called contraction, sir.
Okay. Shortening of muscle. Or after it is short, it is unable to lengthen. What is it?
Fibrosed.
See, fibrosed state of a muscle is a pseudo contracture.
Yes, sir.
And it is too early, doctor. Only 20 days, no?
Yes,
Yeah.
sir.
That much in 20 days, these things will come happen, huh?
He might not have noticed initially, sir, since he developed regurgitation of solids and liquids, and his jaw opening might become a very much
But
problem.
still, total duration of the illness is only 20-25 days. No, it is acute, no?
Yes, sir.
But you want to tell it as contracture?
See, contracture, atrophy, all of these things are long-term processes. For those such a thing to develop in 20 days, the only situation where you have atrophy, wasting, and all is some patient with amyotrophy and all. Otherwise, contractures, atrophy, it happen in long-standing diseases. You have a 20 days illness with the proximal lower limb followed by upper limb weakness. You are bringing in contracture to explain a difficulty in opening mouth fully without any local pain or tenderness, then that is very difficult to correlate, right?
Yes, sir. Yes, sir. Yes, sir.
Doctor, in this patient, it is due to weakness, cranial nerve weakness, okay?
Okay, sir.
Probably involvement of the muscles of mastication. That's what in this patient, okay?
Yes, sir. But
With
he was
muscles
able to
of,
chew, sir.
Hmm?
He was able to
Continue.
chew the food, sir.
Uh,
So
uh, hmm.
he was able to clench the teeth also, sir. But
Okay.
his jaw opening was only restricted, sir. That is
Okay.
what I cannot place the lesion in the
See, at
nerve,
history
sir.
level, at the history level, you might not have a florid weakness. All the patterns might not be evident. That can be explained only when you come into the examination aspect. A patient has got a difficulty in opening mouth fully. It can only be due to a local cause, a nerve involvement, or a muscle involvement. In a patient who has got an acute onset illness with 20 days proximal upper limb, lower limb, and upper limb weakness, and we are considering muscle, I am not no very much concerned that the full spectrum of weakness has evolved. I will be definitely keeping it as a muscle related issue only.
Yes, sir. Okay, sir. Uh, okay, sir. Okay, sir.
You can tell like that. So I would like to confirm this during examination. You can tell. Okay, no problem.
Okay, sir.
Continue.
History of nasal regurgitation for solids and liquids present.
Okay, continue, doctor.
Yes, sir. History of slurring of speech with nasal intonation of voice present. History of difficulty in protecting the tongue and rolling the tongue from side to side, manipulating the food, marshalling the food within the tongue. So this indicates that the patient has a bulbar weakness with the tongue involved. That is hypoglossal involvement, sir.
You can tell that briefly as bulbar muscles and confirm during examination. Okay.
Yes, sir. Yes, sir.
Okay. Okay.
There was no associated pseudobulbar effect, which means that the above described symptoms are less likely due to human involvement, sir.
Continue. Continue.
He was others and all negative history, sir. That is the cranial nerves 1, 2, 3, 4, 6, 7, 8, and possibly partial 11, sir, because he had difficulty in lifting the neck off the pillow, sir. But he didn't have any difficulty in turning the head from side to side, sir. No associated bladder or bowel disturbance. No history of soreness, involuntary movements, incoordination of limbs, tremulousness, seizures, LOC, or memory disturbance. No history of autonomic symptoms. And there was no history of fever, abdominal pain, diarrhea preceding the illness. No history of loss of weight or loss of appetite.
Why are you taking the negative history of loss of appetite and loss of weight?
So because in an older patient who presents with proximal muscle involvement, we have to consider the possibility of Ehlers and Lambert syndromes. That is why I'd like to highlight on the loss of weight or loss of appetite, sir.
Your
Doctor, loss
no,
of weight. Okay. Continue.
your first local thought is about Lambert-Eaton syndrome. In any patient who has got a muscle disease in an acute setting, what is more common than Lambert-Eaton syndrome?
Since he is an older individual, I thought of a paraneoplastic process, sir.
Yeah, paraneoplastic muscle involvement is seen in which group of diseases?
Inflammatory myositis, sir. Dermatomyositis, polymyositis,
So
English myositis.
inflammatory myositis is much more
Yes,
common than
yes, sir.
Lambert-Eaton. No,
Yes,
so
sir.
your first,
Yes, sir.
you should say common things first when we are asking. So here you have proximal muscle weakness of upper limb and lower limb, some facial weakness, and then you have a bulbar weakness. Can you tell me some muscle diseases which can present, no muscle diseases which can have bulbar involvement, or the dysphagia is a prominent component in which all muscle diseases?
OPMD, sir.
Again, doctor, go for
And
the common things. Oculopharyngeal muscular dystrophy. Even though,
yes, sir.
okay, okay, one good thing I can tell you. What is the reason that you will be saved? Because in this patient, you said OPMD first. One advantage. What is it?
Sir, age of onset is more than 60, sir. in
Yeah, so because
OPMD.
of your age of onset, it is okay. Otherwise, OPMD, I have only seen one case. General questions, it is fine. But in this case, you can argue that since the age of onset is 65 and OPMD you said as differential. But again, it is a very slowly progressive disease. So, here, what did we discuss? Can inflammatory myopathies can have they have bulbar involvement?
Yes, sir. Yes, sir. Dermatomyositis, polymyositis can have a bulbar involvement.
Okay,
Inclusion body
okay.
myositis can also have a bulbar involvement. Tongue atrophy, tongue fasciculations can be there, sir.
Yeah, so your age group and your pattern, the first thing that you should say will be inflammatory myopathy, right? It's an
Yes,
acute onset disease. So inflammatory myopathy number one, okay, OPMD. Which are the other muscle diseases which can present with the dysphagia?
sir. Can we tell about NMJ junction disorder, sir?
Let's finish muscle and then come to neuromuscular junction.
So that brown
But which
gland
is the
with
most common muscle disease that you have seen?
FSHD, sir.
Okay, myotonic dystrophy.
Myotonic dystrophy, yes, sir.
Myotonic dystrophy can have dysphagia, no?
Yes, sir.
Inflammatory. So in this setting, inflammatory myopathies, inflammatory myositis, OPMD, myotonic dystrophy, mitochondrial also. Mitochondrial myopathies also can have dysphagia.
Sir. Okay, sir.
And in addition to this, you have neck weakness.
Yes, sir.
What was the patient's neck weakness like?
More of a neck flexion weakness, sir.
Neck flexion weakness.
Yes, sir.
Okay.
That is,
Uh,
he was not able to take the neck off the pillow, sir.
neck flexion weakness when they are driving in cars and all, etc.
Sir, I didn't get the questions.
Patient is traveling in a car.
Yes, sir.
There is a sudden steps on the brake suddenly. What indicates a neck flexion weakness?
Yes, sir. There will be a sudden drop of the head forwards.
So whiplash injury, snapping of the head
Whiplash.
forward. That is why
Yes.
patients with a neck flexion weakness, you advise them to wear collar and all, and sudden deceleration
Top
can
color.
cause,
Yes, sir.
snap. The head can snap forward. Again, so difficulty in lifting head from pillow also again for a neck flexion weakness. Tell me some muscle diseases which can have neck flexion weakness.
Some dermatomyositis, IAM.
Okay, dermatomyositis. Okay. What was the second thing that you said?
FSHD, sir.
No. You said after dermatomyositis, you said something else.
Idiopathic inflammatory myositis, sir.
Those that is neck extension weakness is more common. The patients come with a neck
Neck drop.
neck drop. Neck drop is what you see in inclusion body myositis and idiopathic condition. So that is neck drop, neck extension weakness, not neck flexion.
Yes, sir. Now,
The absence of neck flexion weakness and the presence of neck extension weakness that you see in inclusion body myositis. What is that called?
camptocormia, sir.
Camptocormia is bent spine. It does not have anything to do with neck extension weakness. Paraspinal muscle weakness causing bent spine, that is camptocormia.
Okay, sir. Okay, sir.
Okay. See,
Sir.
what are the one deviation we will take? What is the most characteristic feature in a patient with a muscle disease which helps you to tell that it is muscular dystrophy?
So the pattern of involvement, that is the selective group of muscles which are involved
Yeah.
in specific diseases, sir. We term it as
Yeah.
muscular
So
dystrophy.
selective group of select. Selective group of involvement or differential weakness is something that helps you to say that a muscle disease may be a muscular dystrophy. So, which other group of disease has got selective muscle involvement?
So even inflammatory myositis can have selective involvement, sir.
Yeah,
Like inclusion
yeah.
body
So, inflammatory
myositis.
yes. Yeah, so inflammatory myositis is the other group of disease other than muscular dystrophy, which has got selective. That is why they will have neck extension weakness will be there, but neck flexion will be preserved.
Yes,
Say, which other group of muscles can be selectively involved in inflammatory and muscle disease? Can you tell me?
inclusion body myositis, sir.
Okay, start with that.
Okay, sir. The wrist flexors and knee extensors will be involved in inclusion body myositis, sir.
Finger flexors.
Okay, sir.
Mm.
Okay, sir. Okay, sir. And in
Okay.
dermatomyositis, polymyositis, there will be more of axial weakness, sir. Neck, paraspinal muscles will be more involved, sir.
Okay.
And
Continue, doctor.
yes, sir. Past history, known case of diabetes, hypertension, epilepsy, stroke, CKD, TB, or malignancy. No history of native treatment or drug intake. No history of similar complaints in the past. Personal history takes mixed diet, married, chronic alcohol usage. Last intake 1 month back before admission. No family history. No other members suffer from similar illness. Summary.
Okay, doctor. Okay, see, you tell me what etiology you think in this patient. What is the cause for this patient? Now, at the end of history, you want to tell it is localized to the muscle. Okay, that's what you mean to say.
Yes, sir.
I am telling it is due to radicals. Proximal weakness, I am telling it is due to radicals. Why it is not radicals? You tell me.
So because neck muscles also involved, sir.
Any other thing which you want to tell why it is not radicals?
Radicals
Okay,
can have neck muscle weakness
That's
also. No, that is why in GBS patients and all you are assessing neck weakness, and also you are assessing the single breath count and all.
there
Why
is
are you saying that neck muscle?
thinning of the limbs is there, sir. So it
thinning of limbs,
points to
it can happen in radicals very well. Have you seen acute GB syndrome, which patient is progressing very fast? They can have wasting. Okay, main cause is there is no history which is typically suggestive of root pain. Okay.
yes, sir.
Okay, root pain is one of the clinical feature to differentiate it is from muscle and radical. And also in this patient, there is one odd point which I would like to highlight. You are telling it is inflammation, you are telling it is muscle, but you are telling there is no myalgia, no muscle pain at all.
Yes, sir.
25 days into the illness, no muscle pain at all. You are telling it
No,
is
sir.
no muscle pain.
No,
You are
sir.
very sure? Or did he have any tenderness, or when he keeps hand on the muscle in the upper limb or lower limb, he don't have any pain?
No, sir.
Usually muscle
He
pain.
definitely denied, sir.
Huh?
He definitely denied there is no muscle pain, no localized
No pain at all.
pain or tenderness. No, sir.
Okay, okay. Okay, fine. On examination, okay, fine. Okay. So you feel it is due to muscle, right?
Yes, sir.
Then what is the etiology you feel in this patient? What is the cause?
I would like to consider muscle
What are the
pathology, sir.
possible etiologies? Possible etiologies.
Starting from since due to his
Etiology. Tell me.
due to his age of involvement, I would like to consider paraneoplastic, probably inflammatory myositis due to either dermatomyositis, polymyositis, and or inclusion body myositis, sir.
As the first cause.
Yes, sir.
Inclusion body myositis, don't say path. It is very slowly progressive. No.
Okay, sir.
And the pattern is not inclusion body, don't tell it, okay?
Okay, sir.
You can say inflammatory myositis, but don't say inclusion body in here.
Oh,
20
Doctor,
days progressing. IBM is
doc-
very unlikely.
doctor, did you take history of snake bite?
yes, sir. It's a. Since he was grazing cattle, we asked
Hmm.
specifically for snake bite, sir.
And did you mention it in the chart in your history? So I didn't see it.
Sorry, sir.
So that is
mention
in
it.
that, especially farmer, no, with acute progressive weakness involving muscles and muscles or
But
NMJ.
usually we get ptosis ophthalmoplegia first, sir.
But still you should tell, no, history of snow, bulbar involvement is there, no?
Yes, sir.
You should always tell it, okay? Common things are always common,
Okay, sir.
okay?
Yes, sir.
So you should ask the history, even if you are not written, it is assumed that it is not asked. Okay.
Yes, okay, sir.
Okay. So what etiology you consider inflammatory as a first cause?
Yes, sir.
You can tell inflammatory paraneoplastic, don't tell as the first cause, okay? Inflammatory cause. Or
Sir,
any past
inflammatory
history of febrile infection is there? Past
infection.
history of febrile illness, any febrile illness preceding
No,
the
sir.
current
Preceding
symptom?
the illness. I mentioned, sir.
No, it's
Most
not
of.
there, right? Okay, okay.
No, sir. No, sir.
Okay. Continue.
Neuromuscular junction, sir.
Neuromuscular junction also it's possible you are telling.
Yes, sir.
Yeah, okay,
Why
still
neuromuscular
possible.
junction? You are saying there is no fluctuation. It is a progressive illness. I know there is no diurnal variation, no fatigability, no fluctuation. What prompted you to consider neuromuscular junction?
Sir, because even the test of fatigability might prove otherwise, sir. So I would like to consider a treatable cause first.
So neuromuscular junction is not treatable.
I would like to consider that first, sir. So that is why after muscle, I have placed it as a neuromuscular junction, sir.
If it is NMJ involvement, what are the etiologies that you will consider as part of a neuromuscular junction disease?
His bulbar involvement, sir, his proximal involvement, proximal muscle involvement, both upper limb and lower limbs, sir.
No, what I meant is out of the neuromuscular diseases, the diseases involving neuromuscular junction, which are the ones that you consider in this particular scenario?
Myasthenic syndrome, myasthenia gravis, first ACHR positivity.
See,
Second one is
myasthenia gravis. In here, maybe you can even say LEMS.
LEMS. Yes, sir. Yes, sir. LEMS is also possible.
Yeah.
Since it also started with the bulbar involvement, mask antibody can also be considered, sir.
Okay.
The third possibility will be polyradiculopathy, sir. Polyradiculopathy, sir.
Okay. So there is no sensory symptoms, no? No
No,
sensory
sir.
symptoms, no pain, no numbness, no paresthesia. Why
No, sir.
polyradiculopathy?
No, sir. No, sir.
Then why polyradiculopathy?
Still, the order of preference is the third is motor route, sir.
You don't need to say all the, you see, this is your case differential, not a topic presentation. No, based on your patient symptom, if you don't need to say that a muscle neuromuscular junction, nerve root, anterior horn cell, everything. What is possible in your case, you have to say.
And you are telling something, you have to substantiate it. See, that is the order of preference. It's a general chart, okay? What is
Yes,
applicable to your patient, you can add, you can remove, okay? It is there in the main chart, means you need not tell HC, root, NMJ, muscle in all patients, okay? In
And
your patient,
also, your patient is not alcoholic or anything, right?
he's an alcoholic, sir.
He's an alcoholic. Yeah.
Yes.
metabolic also you are considering, huh?
Metabolic, mostly hypothyroidism or hypoparathyroidism.
Why?
So both can present with proximal muscle involvement, sir.
Such a fast progressive disease with bulbar involvement you see with hypothyroidism.
No,
Less
sir.
likely, no,
Bulbar
sir.
involvement is likely in hypothyroidism, sir.
And 20 days
Hypoparathyroidism.
progressive illness, 20 days progressive illness, bulbar involvement, neck flexion weakness. No, hypothyroidism putting it is quite strange, right?
Yes, sir. Okay, sir.
Because your inflammatory myopathy and all, though you mentioned in your list, it is down in the order. The
Doctor,
last alcohol intake was 1 month back.
did you take any history of drugs intake? Does any specific common medical comorbidities
Yes, sir.
like
Statins, I took steroids, sir. And any over-the-counter medications, NSAIDs, or native medication it takes, sir.
he's taking anything? No.
No, sir.
Okay.
Which are the drugs that can present with such a rapidly progressive muscle involvement?
Penicillamine, sir.
Penicillamine,
Statins,
statins,
statin, steroid,
okay.
colchicine, alcohol, amiodarone
Alcohol,
also, sir.
amiodarone. Alcohol is not a drug. Yeah.
Amiodarone. Yes, sir. Can I move forward, sir?
Yeah, and also your anterior horn cell you have kept in your differential.
I will
Why?
take it, sir.
No, you
Yeah.
need not take, you just substantiate why you have put it. That's all. If you can substantiate, you can keep it there, no problem. But you have to substantiate why you have put it. That's it.
Since it is a pure motor element syndrome, I also consider an anterior horn cell involvement, sir.
Okay, examination.
Yes, sir. Patient conscious, cooperative, poorly built and malnourished. Vitals were stable. There was no drop in sitting or standing BP. Single breath count was 14, sir. And the axillary muscles of respiration were acting. It was an abdominal thoracic type of respiration. IM interfunction MMSC 26/30.
Your single breath count was?
14, sir.
What is a normal single breath count?
25, sir. More than 25.
More than 25. Okay. What does the single breath count measure?
Diaphragmatic weakness, sir.
Doctor? I could not hear. Yeah, single breath count indicates?
The neck flexion and diaphragmatic weakness, sir.
Yeah, flexors of neck, diaphragmatic muscles, and the respiratory muscles. So it's a measure of, it's an indirect measure of what?
The respiratory reserve, sir.
The forced vital capacity.
Vital capacity. Okay. Okay, sir.
So when the single breath count is less than what do you consider? It is one of the indications that the patient may require mechanical ventilation.
Less than 10, sir.
Yeah. Single breath count is checked in lying the supine position or prone position.
Supine position, sir.
No, pa, it is checked in sitting position.
Okay, sir.
Not in supine, not in prone. It is checked in sitting position.
Okay, sir. Okay, sir.
The patient has to breathe out or breathe in before checking single breath count.
Breathe in, sir.
Yeah. Lying down position, if you are checking single breath count, what will be the why it will be spuriously low in a patient with a compromised vital capacity?
But till now we were checking single breath count in supine position, sir.
Okay, so what is the fallacy? If you are having a patient and you are checking the single breath count in a patient who is lying down in supine position, why it will be abnormal? Or why it will be spuriously low?
In patients with abdominal pathology, the patient cannot complete a single breath count. fully,
No,
sir.
no, not that one. See, if there is a diaphragmatic weakness, when the patient is lying down, the diaphragm will be moving up. So it will mechanically limit your respiratory capacity.
Okay, sir.
So lying down, if a patient has diaphragmatic weakness, if the single breath count is low, it will come as even spuriously lower because the diaphragm is at a mechanical disadvantage and it is fixed up. Okay.
Okay, sir. Okay, sir.
So always say check in sitting position.
Okay, sir.
What is the speed with which you are supposed to ask the patient to say? Some patients will just rattle out 1, 2, 3, 4, 5, 6,
Number,
7, 8.
sir.
What is the speed with which they are supposed to say?
1 second, one number, sir.
1 second, two numbers.
Oh.
You have a reference for 1 second, one number?
It was taught by our seniors, sir.
1 second, two numbers is what we have been taught. I also don't have a reference for that, but 1 second, two numbers. 1 second, one number is very slow. Even my single breath count might come as less than 25.
Okay, sir. Moving on to higher mental function. MMSC 26/30 was illiterate, 5th standard only he studied, sir. Immediate recent remote intact, language normal, speech, there was a bulbar dysarthria with a guttural component, sir. I'll show the
Your,
video.
your, MM, your MMSC, so the patient is able to read and write.
He is able to write his name, sir.
Yeah.
Write 2 words, 3 words. That's all, sir. According to the definition, is not literate, sir.
So where did the deficiency come in MMSC?
I didn't get the question, sir.
26 out of
26 by
30,
30,
where all
no?
he made mistakes?
4 points.
Sir, he was not able to copy, sir.
He was not
Then
able to copy, but he is able
yes,
to
sir.
write.
He was able to write the name, sir.
Then copying also he should be able to do. No, you don't need literacy to copy.
Yes, sir. But he didn't. He was
So
not able to
copying
do
was
the intersecting pentagon, sir.
copying was impaired. What else?
That obeying 3-step commands, he skipped 1 step, sir.
Okay.
And
Two.
The reading and obeying commands, he was not able to do. I wrote it in Tamil, sir. Like close your eyes. He was not able to read, sir. And
Okay. So,
one point is recall, sir.
so the reading if he is not able to do because he is illiterate, then the denominator also will come down. No.
But still we have a MMSC of 30. Literate above 28 is normal, sir. Illiterate, we consider above 25 is normal, sir.
24 and less is abnormal.
Yes, sir.
No, what I meant is if the patient is not able to do some activity, then you cannot say it as 26 out of 30. He cannot be tested out of 30, right?
Yes, sir.
Okay, continue.
Okay, sir. Okay, sir. Okay, sir. Speech, bulbar dysarthria with a guttural component. Moving on to the cranial nerves. His first and second nerve was normal. Oculomotor was also normal. Trigeminal nerve, sensation of over the face bilaterally it was present. Clenching of teeth he was able to do, but jaw opening he was not able to do fully. That is, there is restricted jaw opening. Mechanical also we were not able to open the jaw. Jaw closing was normal. Corneal and conjunctival reflex were present. Jaw jerk was absent.
He is
Sir.
opening his jaw. No, okay, right? The photo you have shown.
Yes, sir. He was not able to fully open the jaw, sir. It was restricted, sir.
The patient also feels that it is restricted compared to before. He is not able to open fully. Is what he is saying.
Yes, sir. Yes, sir. This was this photo, sir. That is, he was not able to open the jaw fully, sir. And this was the amount of jaw opening present, sir. Even with the gloved hands, we were not able to fully open the jaw, sir.
Okay.
There was bilaterals orbicularis orus weakness. Orbicularis oculi was good. Frontal is able to wrinkle forehead. Conjunctival corneal reflex present, sir.
The individual
Vestibular cochlea.
muscles, the trigeminal nerve supplied muscles of mastication, individually testing you should have mentioned.
Yes, sir.
Rather
It is
than
very
the
important
jaw
in this
opening, jaw
patient.
He was
closure,
able.
how do you test, pterygoids?
Yes, sir. Later pterygoid by jaw opening, sir. Against resistance. Jaw closing is done by medial pterygoid, masseter, temporalis. Side to side movement of the jaw is done by the contralateral medial pterygoid, sir.
Yeah, so side to side opening and all you have not mentioned in your examination, right?
Yes, sir. But he was able to do, sir.
You have not mentioned means you have not tested. See, primary muscle, see, jaw opening is by lateral pterygoid, no, mainly by lateral pterygoid. So the side to side movement and all you have to mention.
Okay, sir. There was bilateral.
Which muscle is for jaw retraction, doctor? Jaw retraction.
Bilateral medial pterygoid, sir.
Temporalis.
Temporalis.
Okay.
Yes, sorry, sir.
You see, in this patient, the muscles of mastication individual testing and which is weak, which you feel you should be able to test. Still, okay. That is very important. Okay.
Yes, sir. Okay, sir.
Okay, continue.
Bilateral orbicularis oris weakness, but bilateral orbicularis oculi was good. Frontalis was also acting, sir. Loss of pharyngeal and vagus, uvula midplane position, palatal movements, bilateral symmetrical diminished movements, gag reflex bilateral hyperactive. Spinal accessory, turning head against resistance weak bilaterally, shrugging of shoulder against resistance bilaterally weak. Hypoglossal, the power was weak, wasting was present, fibrillation was absent, protrusion of on protrusion of the tongue.
Doctor,
It was
fibrillation is an electrophysiological finding. Okay. What you can see is fasciculation.
Yes, sir. Okay, sir.
Okay, don't tell fibrillation in clinical examination. Okay.
Okay, sir. We have been taught here that fibrillations in tongue and fasciculation elsewhere. That is why
No, tongue
No,
also
no,
we
fibrillation is for a single muscle fiber. You cannot see fibrillation.
it's an
Okay.
electrophysiological finding. Okay.
Yes, sir. Okay,
Don't
sir.
tell fibrillation in tongue, fasciculation elsewhere.
Our senior, sir.
You always tell reference as standard textbooks, not seniors. Okay.
Okay, sir.
Okay, continue. Continue,
Moving
doctor.
on to spinal motor system. Wasting of bilateral deltoid, supraspinatus, infraspinatus.
I just want to tell in your chart you have written this prolonged upgaze something which you are not mentioned.
I have put it in the next slide, sir. Fatigability test.
Okay, tell me. No, that you told for okay, continue.
Yes, sir. Wasting of bilateral deltoid, supraspinatus, infraspinatus, bilateral first FTA wasted, bilateral anterior compartment of thigh muscle wasted. EDB also appears to be wasted, sir. There was no fasciculations elsewhere, even with the
EDB wasting is suggestive of muscle or nerve?
nerve, sir. But this patient had EDB wasting, sir.
Wasting. Okay.
There was no muscle tenderness, sir.
Okay.
There was symmetrical weakness, sir. There was no symmetrical weakness. So I was not able to find any difference between the measurement of upper limb and lower limb. Tone hypotonia of all four limbs. Neck flexors weaker than neck extensors. But there was also neck extensor weakness, sir. Shoulder joint flexion. 3 bilaterally. Extension 4 minus bilaterally. Abduction 3. Adduction 4 minus. The predominant group of muscles involved were in the proximal upper limbs. It was deltoid, supraspinatus, infraspinatus, and pectoralis also, sir.
So there
Elbow
is
joint.
proximal more than distal weakness, but distal weakness also is present.
Yes, sir. Distal, I was not able to find out any pattern of weakness, sir. That is flexion, extension, pronation, supination, everything were 4 minus, sir. Hand grip, I tested specifically for small group muscles, including APB, opponens pollicis, adductor pollicis, extensor pollicis brevis, flexor pollicis brevis, thenar, hypothenar muscles, lumbricals, dorsal and palmar introssi. There was no differential wasting of any involved group of muscles. Everything were weak. Lower limb flexion, iliopsoas involvement were more severe. That is, the burst power was seen with hip flexion, sir. And the second one is hip abduction. That is, gluteus medius and minimus was much affected, sir. But hip extension was 4 minus. Hip adduction was also 4 minus. Knee joint flexion was involved more than extension. Though he told that was buckling of knees, extension was 4 minus, sir. Ankle joint, both dorsal and plantar flexion were 4. EXTEL was weak. Toe grip was also weak. Coming to superficial reflex, bilateral plantar flexor, deep tendon reflex, jaw jerk was absent. Trapezius was also absent. Other reflexes were present, physiologically present. Sensory system examination, cerebral examination was normal. And going on for verticality test, sustained upgaze, no diplopia or no ptosis noted even after 10 seconds of sustained upgaze. Counting numbers after a deep breath, able to count up to maximum of 10 to 12 numbers in one breath. There was no fatigability.
Single breath count was 14. No, now you are saying it is only 10 to 12.
So during the course of the illness, he was in.
No, you are telling at one point when you have taken the case only you are saying, right?
Yes, sir.
So it's contradictory. No, you are saying single breath count was 14, but here you are saying that the patient is only able to count from 10 to 12.
Yes, sir.
Yeah. So don't
250.
contradict your findings.
Yes, sir. Yes, sir. Summarizing history and examination. It's an acute onset, progressive, flaccid type of quadriparesis with symmetrical, predominant proximal more than distal weakness.
You
Lower
can
limb more than
say
upper limb.
element type of you can say rather than flaccid type of, even though it is correct, that may be a better way to say. Acute onset.
Acute onset, progressive, element type of quadriparesis with symmetrical, predominant, proximal more than distal, lower limb more than upper limb, with wasting noted in proximal muscles, without fasciculations, with preserved deep tendon, without sensory or fatigability. Bulbar weakness with trigeminal motor weakness with jaw opening restriction and facial weakness, predominantly of element pattern. So after considering the examination findings, most likely a muscle pathology. Since he is an alcoholic also, toxic myopathy has to be considered, but less likely due to bulbar involvement. Inflammatory myopathy needs to be ruled out. Less likely to be a metabolic pathology. Myasthenia gravis less likely because there is no ocular muscle involvement. LEMS still to be considered, but with retained reflexes, LEMS is also less likely. And polyradiculopathy, reflex are present. There is no radicular pain with a symmetrical weakness, which also goes against polyradiculopathy. And anterior horn cell is very less likely because there is no fasciculations, there is no differential weakness.
Okay. So how do you want to investigate this patient?
Sir, I would like to first do a NCS and RNS study, even though LEMS is less likely.
Routine blood investigations you don't want to do.
Yes, sir.
Doctor,
Yes, sir.
first investigation you should do if you're telling muscle, first investigation, what you should do?
CPK,
RNS,
sir.
huh? That
CPK,
you
sir.
should tell now. Why you want to tell muscle disease and you want to do RNS? Do you think RNS will be positive in all patients with neuromuscular junction disorders? Even in NMJ, RNS will not be positive in all patients, you know?
Sir.
What is the sensitivity of finding myasthenia gravis in a patient with RNS? How much percentage it will be positive in a patient with proven myasthenia? Do you
Yes,
think
sir.
RNS will be positive in majority of the patients?
No, sir. 2/3 cases will be positive. Up to 1/3 can be negative also, sir.
In generalized or ocular?
In generalized, sir.
So even about it will be about 60-70% only it is sensitivity. Okay.
Yes, sir.
So in this patient, RNS is the first test you will do.
No, sir. I will first go for serum CPK.
Okay. So you should tell like that. Basis first basic blood investigations are first.
Yes, sir.
Continue.
Your past differentials where you are saying hypothyroidism, hypoparathyroidism. So always whenever you are seeing a patient, how you will investigate the patient, you say the same thing. Okay.
Yes, sir. Sir, his routines were normal, sir. Even SGOT, SGPT was normal, sir. This was his routine. Total count was 11,600. OTPT was 6842. Viral markers BCTC non-reactive, sir. TFT was normal. Serum calcium was also normal, sir. So serum CPK was 10, which was 5,273 international units per liter, sir. So we said we go ahead and then send for a myositis panel. It's proved to be positive for anti-SRP, sir. And row 52, strongly positive, sir. Other ultrasound for to rule out paraneoplastic, no organomegaly, echo was normal. HRCT to rule out ILD was 10, was normal. ANA was negative. So the final diagnosis being autoimmune necrotizing myopathy, probably anti-SRP4. The patient was started with injection methylprednisolone, 1 gram OD for 5 days. And he was given a tapering dose of steroids at 1 mg per kg per day. And induction phase of the injection rituximab, 1 gram IV, 1 week apart.
Doctor, 1 minute. In this patient, you diagnose that it's a necrotizing myopathy. Which other system which you would like to investigate before starting steroids? Also, it's a muscle disease, no?
Yes, sir.
Which other system which you want to investigate before starting on high dose IV methylprednisolone?
The TB
And
should be ruled out, sir.
Huh?
TB, sir.
TB?
Tuberculosis, sir.
Huh?
Tuberculosis.
No, now he is an elderly man. You found diagnosed a muscle disease with that such a high
CA lung,
CPK.
sir.
Huh?
CA lung, sir.
CA lung.
Yes, sir. Small cell carcinoma.
Don't you want to do a basic cardiovascular examination, get an echo done to make sure that there is no cardiomyopathy or there is no before starting high dose steroids?
Yes, sir. Echo did, sir. No
Ah.
regional motion abnormality. EF was 56%.
Okay. So any patient with a muscle disease, cardiovascular examination is very important. Echo is important before starting high dose steroids. Okay, because you give steroids, sometimes there is cardiomyopathy, patient can go for failure immediately.
Yes, sir.
Okay, continue.
Yes, sir.
Continue.
The patient was given injection rituximab 1 gram IV, 2 doses, 1 week apart, 2 doses. And also managed supportively since he had regurgitation of fluids. We put him on Ryle's tube and maintain the oral nutrition, sir.
Okay.
Sir.
How is the patient doing now? He has improved.
Sir, no, sir. Actually, 2 weeks back he passed away, sir.
Okay.
We called him for the third dose of rituximab, sir.
Okay. What was the cause of death?
Sir, they didn't know, sir. One day morning, he was found lying unconscious. They took him to a nearby hospital. He was found dead, sir.
By default, this necrotizing myopathy is refractory to immunomodulation.
Yes, sir.
Okay.
Yes, sir. We also plan for a muscle biopsy also, sir.
Mm.
So this is the latest ENMC criteria for immune-mediated necrotizing myopathy, sir.
Mm.
Anti-SRP4 serological criteria. If there is anti-SRP4 antibody positivity, there is no further muscle biopsy features required, and high creatine kinase with proximal muscle weakness can confirm the anti-SRP myositis. And if there is antibody negative immune-mediated necrotizing myositis, then muscle biopsy has to be done to look for necrosis, myophagocytosis, and regeneration. But there will be lymphocytic infiltrate.
Okay.
Yes, sir.
In the acute setting, would you do an arterial blood gas for this patient and why?
EPG. Sir, for respiratory muscle involvement, when patient has a diaphragmatic weakness, he might have respiratory acidosis.
Yeah, so carbon dioxide retention. So many a time when you have patients with acute polyradicular neuropathy, acute muscle disease with diaphragmatic involvement, CO2 retention, respiratory acidosis, these are another reason why these people can go for acute cardiorespiratory involvement, arrest and all. So the blood gases also you should check in these patients.
Okay, sir.
Okay. I think we can conclude the session now, Dr. Krishna.
Yes, Dr. Priyan.
Yes. Doctor, anyway, you presented well. It's a good case. Sadly, the outcome was not good. Let's see if it's a learning experience.
Yes, sir.
Okay.
Yes. Thank you, sir. Thank you, sir.
Okay. Dr. Shailish, shall we conclude?
Yeah, anybody have any question they can ask?
Somebody has asked in the chat box, necrotizing myopathy, can it present without myalgia? Yes. Statin-induced myositis, when they have necrotizing myopathy, myalgia need not always be present.
There are no further questions. There are some. How to test small jaw muscles? Can you?
Okay,
Doctor?
we will Yeah.
Doctor, you want to answer?
Sir, what is the question, sir?
See, the masseter lateral pterygoid, how to test is what they are asking.
The lateral pterygoid is by jaw opening, sir.
Okay.
Masseter, by clenching of the teeth, we have to look for the masseter prominence, sir.
Okay. Then
Sir, either
lateral movements.
lateral movement by medial pterygoid, the opposite medial pterygoid, sir.
Okay. Then
And
protrusion.
protrusion by temporalis, retraction.
Protrusion by temporalis and lateral pterygoid.
Okay, sir.
Okay.
Retraction by both medial pterygoid, sir.
Okay. Okay. Thank you.
Yes, thank you, sir. Thank you, sir. So there is one video of the patient, how he gets up, sir.
Yeah, you can show the video.
Thank you, sir.
Actually, it's not playing, sir. I will share it in the group, sir.
Okay.
Sir, I have a doubt. May I ask, sir? May I ask a doubt, sir?
Yeah.
Sir, in the section on inflammatory myositis in the Bradley's textbook, I was surprised to find that it said prominence of pain is rare in polymyositis. In fact, the presence of excessive pain should prompt an alternate diagnosis. But is that true in our clinical experience, sir?
Yes, polymyositis is a diagnosis of exclusion. You see this signal recognition particle being positive,
Yes, sir.
anti-synthetase. All of these inflammatory myositis, the antibodies which are proven to be positive, they are not included under polymyositis per se. There is
Yes,
no
sir.
skin involvement, no pain, no other findings. So polymyositis is basically a biopsy-based diagnosis, and it's a diagnosis of exclusion. So prominence of pain, all of those things take it away from polymyositis.
With the exception of necrotizing myositis, other inflammatory myositis syndromes, all of them are unlikely to be painful, sir, including
Dermatomyositis,
dermatomyositis.
the patients will have pain.
Yes, sir. Okay, sir. Right, sir. Thank you, sir.
And the synthetase syndromes also. Anti-synthetase antibodies. So dermatomyositis, necrotizing myositis, and these antibody positive syndromes, all of them can
Yes, sir.
have pain.
Okay, sir. So it correlates with the presence of pathogenic antibodies if the syndromes in which they are present are more likely to be painful, is the conclusion. That is the conclusion, sir.
Not like that. See, absence of pain maybe points to conditions like myopathies, inclusion body myopathies, polymyositis. Presence of pain
Yes.
correlates with the other ones. You cannot say that the opposite way.
Okay, sir. Okay, sir.
Yeah.
Thank you, sir.
Okay. Then we will conclude that.